Good afternoon, everyone. Okay, let's settle down. Maybe the speakers can come to the desk. Okay, so for those people who are on time, so thank you so much. So let's begin. Um, and but we can still have some people coming in because of the break, and also this is probably the last session. Okay, so to begin, so my name is Gaj Gurung, and I work with Harm Reduction International as a senior analyst, and I'm going to chair this amazing session today. So before I start, just wondering, like, how many people were in the funding session this morning? That's awesome. So this room is going to be a funding room now. We need to generate funding speakers. Jokes around. Okay. So just following on the discussion since this morning on the funding, if you remember, a lot of speakers talked about the sustainability of the harm reduction. And one of the very viable option was the domestic funding, right? So today on this session, we'll explore different avenues of the domestic funding, which can probably lead us to the sustainability in this time of crisis. So today in this session, we're no, for the sustainability, we just don't talk about money, but we also about some of the approaches that the countries have adopted, very innovative, approaches with different financing mechanisms like health insurance, integrations, social contracting. So there are a lot of, there are a lot of ways in which we can work with the government, where we can influence the government, or we can generate funding from the government. So this afternoon we will, um, listen to all those amazing presentations. So the title of the today's session, I thought it would be here, but it's not here. So it's to secure the future, building sustainable domestic funding for harm reduction. Okay, so the title itself is very self-explanatory. So without further ado, I'd like to invite our the first speaker, um, Paulina. So I'll just call Paulina. I'll not call your full name. So Paulina is my colleague. We work together at Harm Reduction International. She's the project coordinator and researcher in the public health and social policy team at Harm Reduction International. She's a gender and drug policy specialist, researcher, and human rights advocate with a background in promoting social justice. And she'll be setting the context by providing a global scenario on the state of the harm reduction. And through there, we'll go through the other presentations. So the floor is yours. And you have 12 minutes.
I'm sorry, I'm gonna just present myself first in Spanish for those who speak Spanish. Hola a todos, mi nombre es Paulina Cortez, soy de México. Desafortunadamente no voy a estar presentando hoy en español, una cuestión también logística y con la mesa, pero si tienen alguna duda y quieren hablar conmigo en español al respecto, son bienvenidos. Okay, so hi everybody, my name is Paulina Cortez. I work at HRI. I am the project coordinator and researcher in the public health and social policy team. So I'm gonna be presenting today some of the main findings from one of our flagship reports, which is called Global State of Harm Reduction. Some of you maybe already know about this report, or maybe even responded or survey. So thank you so much, by the way, because without you, obviously this report won't be possible. And I'm sorry that I'm just taking my notes in my phone. I'm a very short person, and I didn't realize that this is gonna be really like tall. So my computer is basically on my face if I do that. Anyways, so The global state of harm reduction, for those that don't know about it, is a report that happens every 2 years, and it includes 9 different regional chapters that are authored by experts from each region. And also, the report emphasizes some of the harm reduction main issues in every single region, but also in some marginalized communities, neglected communities. So in this new edition that we had last year, we had some thematic chapters as well, which, by the way, I can see one of the authors for the indigenous chapter here. So what we do is like basically we have experts from each region, experts for each thematic / community that we are talking about. This is kind of inventory of what we have, because we want to understand what is still left, what we need and we don't have yet. Okay, so we have different services that we report. One of these services is the opioid agonist therapy. Because we are doing it every 2 years, then we can compare how the harm reduction services are expanding around the world. And between the year of 2022 and 2024, we have 6 new countries that now offer opioid agonist therapy. You can see in this part of the slide which are the countries, and unfortunately we cannot report opioid agonist therapy anymore in Nigeria. This is how the world looks like with the availability of the opioid agonist therapy in the community and in prisons. And as you can see, there is a lot of places around the world, a lot of countries where we still need to cover services. Another important service, harm reduction service that we also report is the needle and syringe programs. Between the year 2022 and 2024, we only have 1 more country integrated to the list. We actually have more than 1, but the problem is like we have 2 countries that are not having NSP anymore. So it's why the total amount is only 1. But I think it is important that even though it seems like a small step, we need these kind of steps every year. Hopefully we can get higher numbers next time, but I think that the point is like keep going and extending these services. This is how the map of the entire world looks in terms of like the needle and syringe programs around the world, again in the community and in prisons. We also report on drug consumption rooms. We actually were really happy about the last report on this, because we have the Sierra Leone. For the first time in Africa, we have 1 drug consumption room, and this is amazing, and I hope that this also opens the possibility for more and more countries to join this list. We also have Colombia, which is many of you might already visit or are planning to visit the drug consumption room here. Is from our colleagues of ATS, which are our partners in this conference, and they have a project that is called Cambie. So I invite you all to, now that you are here in Colombia, to engage also with the people that is behind this drug consumption room. We also have the number of countries with take-home naloxone. As you can see also, this is actually really low considering how important naloxone is. So I think it's just kind of like a snapshot, a reality check for all of us on what we need to expand, what we need to work on, and especially look for funding to support these programs and to expand them. We have safer smoking kits, which is very particularly important in regions like Latin America. So maybe some of you already know, but like in Latin America, we actually have more discussions about stimulants rather than opioids. And I think it's important to also contextualize the harm reduction services that we need specifically for each region and country. And I think that smoking kits are really important in regions like Latin America, definitely. So hopefully we can start having more of these services all around the world, but also in the region. It's still a very low number, but I think that we are having an increase of the safer smoking kit services right now. Between the 2022 and 2024, you can see that we have 6 more countries. Okay, so this is a little bit more about the NSPs that are available in at least one prison. So we have 11 countries. Last year, we report 11 countries that have NSP. And that you can see like in which part of the world we identified these countries. Obviously, this in comparison with the community is really low. And these are one of the main communities, one of the main populations that we need to take into consideration when it comes to NSP. So we also have the report on OAT, and it's available at least in one prison in 60 countries. This is good, but it's not enough because obviously compared to the communities, which is 94, we are still a little bit behind as we should be. And this number should be even more and more, of course. So one interesting thing for me is that in the report, we found out that 108 countries are actually supporting harm reduction in their national policy documents. And this sounds really amazing because it's a lot of countries, but what is happening between that and the problem that we have with funding? Because the funding required for harm reduction, the actual funding that we have is only the 6%. So why we have so much support in the policies on the paper, but then how we can move forward to go beyond the paper and into the action, into the funding, into putting the money where it's needed, right? So we presented the amount of money that this 6% is about. So it's like 101.6 millions are from donors, and then the 49.7 millions is from domestic budget. So as you can see, like there's still a lot of things to do in terms of like how much money we can advocate for in the national level. Why is this important? I mean, obviously, all the numbers that I just discussed right now are the numbers from last year. And I'm really afraid that obviously this might be changing this year and the next following years. We know that we are facing a complicated situation with the funding. We already had a very complicated scenario with the funding in harm reduction, but now it's kind of even more complicated. So I think it is important to keep in mind that it's so important to invest in justice, invest in harm reduction services, and other services and programs that prioritize health, community, over punishment and unjust laws. So here's an example about what I mean in terms of like how we can divest that money. So you can see there that there is 151 million current funding for harm reduction and in low and middle income countries. And what is estimated to be needed is 2.7 billions. So we are really behind our goal. And in comparison, we have the global drug law enforcement expenditure per year, which is $100 billion. So if we stop like putting that money into that and we divest money into what we need, I think that it would be amazing and it would definitely save lives. And I am aware that I don't have more time, but please contact me if you have any questions. I acknowledge that this report is a product of a lot of people. I'm just here to voice a little bit of our work, but it's definitely a collective effort. So you can see some of the names in there that are part of this amazing report. And I hope that you can also be part of it. We are going to be sending surveys really soon. And I know that sometimes we don't want to be responding surveys, but I promise to you is because we want to have enough data, updated data, so we can use it as a tool for advocacy. So thank you so much.
Thank you, Paulina. Very timely. I mean, since this is the last session, people are tired. So instead of listening to another presentation, I open for one burning question, if you have any. One burning question from one of you, if there is any question. One. Okay? No? Okay then. So I'll go for the next presenter then. He is, it's not easy to pronounce your name, but so I always call him Achil. I mean, that's what he's famous for. So Achil works with the organization called Rumah Cemara, and he's from Indonesia. He represents people who use drugs, and he's been advocating for the national narcotics regulation and budget for harm reduction in Indonesia. And today he will be speaking on the context of the domestic funding, and in particularly social contracting, in terms of how the community can, advocate the government and access the social contracting, right? You want to come here, or you want to do from there? Yeah, you can also do from there.
Check. Good afternoon, everyone. Yeah, I think this is the latest session, and everybody energy is going down, but we try to make it fast. Okay. I want to talk about the domestic public financing and social contracting for harm reduction program in Indonesia. For this one, for the beginning, I want to try to make a mapping about the domestic funding landscape on harm reduction in Indonesia. This to see about the overview of current funding source supporting key harm reduction component in Indonesia, and highlighting the roles of international donor, national and subnational budget. Why this is very important? Because to understand what kind of budget that we want to advocate to government. And also this is very important to take the roles of the civil society to working on this. But for the notice, this is the component based on the Ministry Health of Regulation in Indonesia. First, for the NSP, it's support from from Global Fund and national budget, and also subnational budget. For the methadone maintenance treatment, it's support by Global Fund, national budget, and also subnational budget. For voluntary counseling and test, it also support from Global Fund, national budget, and subnational budget. And for information, education, and communication, the three supporting from Global Fund, national budget, and subnational budget. From IRT, it's support only from Global Fund, about 10%, and from the national budget is already support for 90%. For hepatitis prevention and care is already support from the national budget, 100%. And for TB prevention in support from Global Fund and national budget. This for the civil society, especially for outreach, is only support from Global Fund. National budget didn't support for this, but in some district and city, they also support for outreach and others others international NGO also support in small area in Indonesia. Social contracting and harm reduction. Why this is important? Yeah, social contracting will be important mechanism for maintaining and enhancing the role of community and civil society organization when government, not international donor, are the source of the fund. The note is it should be government funding, not international donor. To get the government support, it should be have the regulation who support the government. That's why we make a mapping about the regulation that can support the government for harm reduction. In Indonesia experience, we have a narcotic regulation that on process to revision. The Article 56 for prison regulation is a basic regulation for support harm reduction. And the others, but the problem in the process of revision, this article already deleted by government. So it will be become a heavy for harm reduction get support from the government funding if we are not advocate the narcotic regulation process revision. The second one is Ministry of Health Regulation number 23 years 2022. The other is about President Regulation number 16 years 2018 about self-management. The others is Ministry of Home Affairs Regulation number 1990 years 2019 about guideline for providing grants and social assistance from domestic budget. The other one is Government Regulation number 23 years 2014 about area autonomy, because Indonesia have for the budget in the city district level, they should develop by themselves. And the other is city and district regulation. There's a lot of regulation to about development budget for their area. This is the advocacy strategy developed by Rumah Cemara to initiate social contracting in Indonesia. First, we make a mapping regulation that I told before, and then we make a stakeholder mapping. We also training the community lead organization about the budget policy and process. And then we develop policy paper, lobbying and advocate, and also make a regular coordination with budget domestic forum. After we create policy brief related to harm reduction budget, we communicating with the policy paper to the local government, conduct intensive communication, because there's a lot of stakeholder in the government, not only health office, but also have a social office, major office, and others office that related with the people who use drug, including City National Narcotic Board. And then we made a budget analysis workshop. We developed network advocacy work plan. And the network advocacy work plan include the type of activity the related government, capacity of civil society related budget advocacy will be increased. To understand about the budget development, we need to understand about annual planning and budget process from the government. This is very important to understanding the annual planning and budget cycle is a key for civil society to engage meaningfully in local development process and advocate for harm reduction funding within existing mechanism. Why? Because if we want to have a sustainability, we must involve in the process. become I understand about the process, become I dizzy about the process. Actually, if you see this, the local government should be have a medium term which in line with strategic plan in local government. And then local government should have initial plan. And the budget process should be start from the village community consultation. And then to the sub-district community consultation, to local government forum, and then make a local level community consultation on development planning. They already put in each month regularly. And then go to the provincial level community consultation. And in April, they also in the national level community consultation. This process is need a lot of effort. And also in October, they will decide what kind of budget can distribute in the city and district level. What are the results which Rumah Cemara do? 6 HIV Budget Advocacy Forum of Civil Society developed on 5 provinces, West Sumatra, West Java, Yogyakarta, South Borneo, and West Papua, and also Bali. And 2 provinces focus also on harm reduction budget, West Java and Bali. For HIV advocacy budget is more easy, depend on the harm reduction budget, because the stigma and criminalize of people who use drug is worse in Indonesia. Like I said before, that in the narcotic regulation, we are in the process revision, and also I become one of the legal draft team in the Ministry of Law, and we are success to add the harm reduction philosophy, become a basic value of latest draft narcotic and psychotropic regulation development. The forum actively focus on harm reduction issue in Denpasar and Bandung, and I forgot to add 2 things. One NGO in Denpasar got Swakelola Type 3, is a social contracting for KVP.
2 minutes. 2 minutes.
Okay, for KVP outreach, including people who use drug. And one NGO in Bandung got social grant for harm reduction initiative meeting with stakeholder. To get everything like that, we must understand about budget politics, because we should understand about what is the political thing in the budget holder about what they want to do in their city. What is the challenge? There's a lot of challenge actually, because only limited harm reduction organization registered on Agency for Political Development and Community Empowerment as a recruitment of social contracting. And in the city and district level, is very limited harm reduction organization had annual audit as a recruitment of social contracting. Awareness of organization about domestic funding needed is become a challenge, because they think that the donor is only for from the international donor. The other thing, the challenge is stakeholder perspective about harm reduction itself. And the other challenge is drug trend change in Southeast Asia. We are not in the opiate trend anymore in Southeast Asia, especially Indonesia. We are become a methamphetamine trend. For this year, we have also challenged budget efficiency from government. Ministry of Health cut 40% from their budget from government. It's become a challenge, another challenge. What is the recommendation? Changing perspective of stakeholder about harm reduction. Strengthening of harm reduction civil society about governance and financial audit, annual audit. Increasing funding support for advocacy activity. Like I said before, a lot of effort needed for the monitoring the budget development. Regular strengthening of civil society to monitoring budget planning and implementation. This is some of the documentation in Bandung and Denpasar. Thank you.
Thank you. Thank you, Achil. I think it was a complete package of the context, strategy, and the result. So, any burning question before we go to the next speaker? No? Okay. And also just to add that, the result and the social contracting for harm reduction that he presented is rare in our region, especially in the Asia Pacific region. I'm also from Nepal, so I said our region. So there are very few examples where the harm reduction has received the government funding, and in particular the social contracting. So this is amazing. So I go to now the next speaker. We talked about the global context, national context, and funding. So now we go a little deeper into some of the specific funding mechanism. So for that, I invite Henry Lucas. Henry is the owner of Loose Vial Health and Healing, and he's the CEO of Kentucky Harm Reduction Coalition. With a passion of transformative healing, Henry is also a certified psychedelic assisted therapist and the author of Maximize.
Hey, good afternoon. Good afternoon. I'm glad to be here. Really grateful to be here. Thank you for allowing Americans to come into your country. I'm really grateful for that. Love your country. It's beautiful. And I'm going to talk about a pilot program that we've done in Kentucky between a health insurance company. And before, is that better? Before I do that, I want to give acknowledgement to my co-presenter, Dr. Rachel Vickers-Smith, who is a researcher and professor at the University of Louisville College of Public Health. Another shout out to some team members, Erica Williams-Archie, who's the Director of Operations, Dr. Amanda Fallon Bennett, who's also a researcher and professor at the University of Kentucky. And I introduced them because I really want you to meet my friends. My friends do really cool things. I just happen to be up here talking. And my friend Cielo will be presenting transformational breath work tomorrow at 1 p.m. You definitely don't want to miss that. So I think, really before we get started about the pilot program, let's just take a look at what we're really looking at here in Kentucky. So there on the left is Kentucky in red, and they say that we're in the South. We're not really in the South or the Midwest. Just a really odd positioning of a state. And if you look to the right, we have 120 total counties, which is a lot, and each county really has its own sort of authority. And so it can be really hard to get things done on a large scale across the state because a lot of these counties, they prefer to do their own thing. And Kentucky, outside of a couple major cities, is really a pretty rural area. And I wanted to show this to you because Kentucky is the epicenter for the opioid crisis. This is where the opioid crisis started in the United States. And partly, if you look to the right of the state, it is some of the oldest foothills, a mountainous region in the United States, eastern Kentucky and Appalachia. And the opioid crisis in Kentucky was a direct result of economic crisis, economic collapse, cultural stigma. Were positioned quite nicely in the Bible Belt and in the Rust Belt. And what we're really talking about today is the need for homegrown, sustainable, domestic harm reduction funding. So welcome to Kentucky. We are the bluegrass state. We lead in a lot of areas that I'm not quite proud of. If you look over to the right, HIV infection rate, we're the 20th state for that. Hepatitis C, we rank fourth. The overdose death rate, we rank second. We lose in the state of Kentucky. A little over 2,000 Kentuckians a year die from an opioid fatal overdose. It was actually down in 2023, just below 2,000. And we celebrated a 9% decrease in fatal overdose deaths, but we saw, I think, a 12%, 13% increase in the black and brown communities. So nothing really to celebrate there. We're at the top of the list for poverty rate. We're at the top of the list for the literacy rate. And compared to Bogotá's population, we are about half of that in a whole state that's not even nearly as big as Colombia. So the state has really been ravaged. In 10 years ago, we're coming up on 11 years actually, Kentucky Harm Reduction Coalition was founded. And I want to go through the history because it's really important to see what happens when caring, committed, compassionate citizens come together to form an alliance. I believe it's really the only thing that's going to create the sustainable change that we need is when we all meet around the table to share the same pain and the same concerns. And so we were founded on parents who have lost their children to overdose, and they wanted to do something different. And so they started with naloxone distribution very early on. And in almost 11 years, we have distributed over 1 million doses of naloxone in the state of Kentucky. We've hosted over 500 trainings. From 2022 to 2024, we distributed over 1 million fentanyl test strips in the state of Kentucky. And for most of that time, fentanyl test strips were considered illegal. In 2020, we launched the first mail-based distribution in the state of Kentucky. We have mobile sites. We helped push the first syringe exchange program in Kentucky. We have health kiosk, and I skipped over the health, it's supposed to be health and wellness lounge, which I'll be talking a bit about today. And these are progressive things, and this is really a big deal for a super conservative, super religious state. These are some pictures of some of our folks. Up to the top right, we were in New York City at Bloomberg's initiative. Down at the bottom right is Dr. Murphy, the co-chair for the board. We are at University of Louisville School of Medicine. These are for first-year med school students. Now all go through a naloxone training that we provide for them. And in Kentucky, in the United States, in Colombia, all over the world, we are all sort of experiencing, challenging times, right? And I think the biggest challenge, that we're dealing with is the stigma and the bias, and how ingrained, that is in communities and culture and in policies. And I was at the funding session this morning, and a lot of similar challenges all over the world. One thing, though, Kentucky, a few years back, we received some opioid settlement money. We got almost $900 million over the course of about 18 years. We did apply, and we were awarded with money for a very short period of time. And so we go back up to, renew this. And it's very hard to get continuing, ongoing, long-term, funding from some of these sources. So unfortunately, we create programs, and without funding, those programs are generally the first to go. The personnel are usually the first to go. And so I took a step back and I looked at, well, what is it? So we have a vision of what we want our state to look like, and we definitely know through the media and through data and through anecdotal accounts that there is a need And when you apply action to that, that is actually how you get innovation. And I believe that, at least in the state of Kentucky, if we are going to move things forward, we have to really consider doing things that haven't been done and having conversations with people that we generally don't talk to. One of our partners, Vital Strategies, introduced us to an insurance company that's pretty predominant in the state of Kentucky. They are a MCO, which is a managed care organization. They provide Medicaid insurance coverage, and we really thought that was important to have a conversation. And whether it's with the insurance company, if it's with Vital Strategies, if it's with the opioid abatement, it's really important to find out what their values are. Like, what are the things that these organizations or these people hold really close to their heart, so that we can use that as leverage of why we need to partner and why we are really committed and to making significant change. So a little bit about insurance companies. Are they a viable funding source? They are. They can be incredibly challenging to work with because they are so bureaucratic and there are so many departments. And I'll share a little bit of the challenges that we had, but it really is in insurance companies. It's really in their best interest to fund harm reduction, because so much money is spent on unnecessary admissions through the emergency room, through the emergency department at hospitals, which is exactly what this harm reduction navigation of care that we partnered with Anthem, what we were really targeting to do here. So we were awarded $100,000 for 1 year, which we're really grateful for. And in conversations with Anthem, this 100K would save them about 20 million. And I don't know why. I just thought about this, but I'm sitting 2 minutes already. So I don't know why, but I'm sitting over there and I'm thinking about the challenges we had on the back end and how much money we were awarded on the front end. And 100K is not really a lot of money at all. And so if I could go back and redo it again, I would tell Anthem to put your money where your mouth is, and that if you really want to work with us, we're going to need more than $100,000, because that's not really any skin in the game if you're going to save $20 million off $100,000. We collaborate with hospitals, harm reduction organizations, insurance companies to establish a brick and mortar, which we've called our Health and Wellness Lounge. Couple pictures there that I wouldn't really get into, though. The bottom right, let me give a shout out to the lady on the right in front of me, Sharita Walden, who's our executive director. This is what our process looked like. So we partnered with Damon Williams, who is the founder of Omni Resources, which is Grassroots healthcare organization. They would communicate with the University of Louisville Hospital, and we would intervene to do a harm reduction needs assessment. We would transport the individual to our Health and Wellness Lounge, and then we would link them to care. And what that would look like would be food, housing, treatment, harm reduction supplies, education. And what we found was there were really three biggest needs that had nothing to do with drug consumption or substance use. Most basic needs, shelter, water, and restrooms. And as a result of that, because there's no public restrooms, you can't use a public restroom anywhere in the city that we were doing this. And so one of the things, so that folks could use the restroom, we developed, incorporated a timed restroom strategy. So folks would use the restroom. If they wanted to use in a restroom, they could, if that was their choice. And we also had a time so that we could prevent any unnecessary overdoses. And actually, in the last year, we were able to prevent maybe like 6 or 7 overdoses on site. So I'm running out of time here. But just like some growth opportunities, like if I could do it all over, I would go back and really tell Anthem to put their money where their mouth is. That we're not going to do anything under a year or anything under $100,000, so that we could get the ongoing commitment from them. It felt like towards the end, it was really more about charity for them, and that they felt really good about helping a very small grassroots organization. But we all know that this work isn't about feeling good, that this work is really about stepping up and showing up in places that most people will dare not go, and to see things that most people will not see in their lifetime. And so, building partnerships, streamlining the process, looking at collaboration with other small organizations, or creating the processes to do these things in house. And then really looking at all the creative ways that we can continue to compile the data. And so one of the things that's on our list now that we've had this and we've been able to breathe is to go back to the other MCOs and to have a pitch to see if they would be interested in partnering and collaborating, because we know that harm reduction, we know it saves lives, but it also not, but, and there's also great economic impact that harm reduction can really have, especially for a state like Kentucky. So here's my contact information. Please reach out. I'd love to entertain any sort of conversation about anything. So thank you very much.
And can you hear now? Sorry, I have a. Okay, so in the interest of time, so I move to another speaker. Unless if anyone has any questions, like just following the norms. No. Okay. So we have the final speaker now, but a very meaty presentation. I mean, we had a. Just to, again, if I have to repeat, we have a global context, national context. We have very specific examples of innovative financing or partnership. And finally, now we have integration. So Mohammad Shoriful Alam is the native of Bangladesh, working around 20 years as an activist in the area of HIV intervention program among people who use drugs and people living with HIV. And he will be talking about the integrations of prevention services for people who use drugs into the public health system for the sustainability. So all the transition from the NGO-led to government-operated services. The floor is yours.
Good afternoon, everyone. I am Mohammad Shoriful Alam, HIV activist working in Bangladesh as a technical specialist, community system strengthening for people who inject drugs. So before going to my main presentation, I would like to summarize the background of HIV prevention program in Bangladesh, the main milestone of HIV prevention program. Basically, HIV prevention program was started in 1995 for the female sex workers. And in 1995 to 2000, gradually started working for people who use drugs, MSM, and also transgender. And then health sector program, basically it is funded by the World Bank and implemented by NGOs. It was started in 2004, and then Global Fund came to Bangladesh for funding, and it started from 2008, and already 6 grant has been implemented so far, and the GC7 has been started in January 2024. Along with NGO, AIDS STD program, that is a national nodal body for HIV, ASP, in a short form. AIDS STD program started direct implementation since 2021 in 5 districts. And then Save the Children, where I am working, implementing intervention for people who inject drugs and female sex workers in 31 districts out of 64 districts in Bangladesh. and relocation process, that is integration and relocation process, started in 2021, but reinforced under NFM3 grants since 2022. Now the main question is why relocation is required. And the main thing is that relocation is required for the sustainability. The main thing is that funding is decreasing day by day, and it is imperative that donor funding will be away, and we have to survive by our own resource, and that is important thing. And another thing is we have to maximize the opportunity for the key populations, because in a private setting we don't have all the services for our KPs, and in particular all essential service we can ensure from government hospital, and also stigma and discrimination through normalization of all services. And then it obviously cost effective, that we will see in the next slide how integration and relocation has become cost effective. So for relocation and integration process involve basically multiple stages. One is relocation, basically shifting a drop-in center into a government hospital. That is one phase. And another one is preparedness of government through through training, sensitization, and necessary arrangement for human resource, logistics support, etc., and service integration. These are the key elements for integration. And this is probably is not very much useful for you. This is the list where the integration process has been completed. There are 15 hospitals has been already providing service for people who inject drugs in Bangladesh, and the category of hospitals are district level hospitals and divisional level hospitals and tertiary level hospitals. Now, I would like to describe how the integration process was done, because it is very challenging. We know stigma and discrimination persist everywhere, and government hospital is very busy, and they don't give any space for additional service for particularly key population. So to make it happen, basically we started in three. If we divide in three phase, one is selection phase, and then approval phase, and third one is implementation phase. In selection phase, we have done it in Global Fund supported program, because we know if it is not planned in the work plan and budget, it is difficult to include a new new activity in the Global Fund system. So during proposal development, we basically plan for integration, and then we select some hospitals based on the epidemiology of HIV, and also the outreach location from the hospitals, and also the availability of space. These are the initial criteria for selecting hospitals. Then in approval process, basically we have a nodal body in Bangladesh named AIDS STD program. AIDS STD, we coordinate with AIDS STD program, and AIDS STD program issue a letter to the respective hospital for giving space for the service of people who use drugs. And with this letter, we pursue the hospital, and it is not very easy to identify or to get a letter from a hospital for space. But with a regular communication and with a letter of government nodal body, we get space from the hospital, and then finally the space is not automatically ready, and it has been it is being renovated, or refurbishment work is being done by the Global Fund grant. That is the way we basically complete the approval process. And then for make it happen, we develop management implementation plan and implementation guidance note, how the service center is will be operated in the hospital. And also we develop monitoring tools, we develop protocol of reporting and also coordination. And we also engage network of people who use drugs to make ready for the key population, because readiness is both way matter, because health service provider are not very much welcoming to provide service for the key population. At the same time, key populations are not very much interested to go to the hospital. So it's a both way matter. We engage a network of people who use drugs to motivate and to make ready for the people who use drugs to bring them in the hospital. At the same time, we basically develop some tools that is shown here: implementation guidance note, monitoring tools, and also assessment. So what is basically the main points in guidance note, that is infrastructure. What will be the infrastructure in hospital? Because scarcity of space, so we need at least 2 or 3 rooms for operating a service for people who inject drugs. It depends on what type of service we are giving. If it includes ART, OST, and also other out service, then the room is required at least 3. And if it only out service and only needle syringe program, then we need 2 room. And in guidance note, it is suggested that if hospital provide only 1 room, we should take the opportunity, and gradually after taking 1 room, we can negotiate with the hospital, and gradually we can expand the space. And that's the way we are working. And the second issue is human resource. And we start with the human resource by the Global Fund, and gradually we work with the hospital, and hospital is supposed to provide technical staff to provide clinical service. And service hour, in guidance note, it is mentioned that service hour in government hospital generally open from 8 a.m. to 2 p.m. But it's difficult for provide service within this time period. So we open this service center up to 4 p.m. And then we provide training to the healthcare providers. And also in the hospital premises, some general population are interested for HIV testing. As per guidance note, though it is the service center for key population, but we provide HIV testing for general population as well for the mainstreaming of service. And there are some other issues, referral and also surgical management of people living with HIV.
2 minutes.
And also there are monitoring guidelines and coordination and also troubleshooting management. These are the monitoring tools. What type of things will be monitored? These are the outreach and center-based activity, health education, clinical information, HIV testing, universal precaution, and OST service training, and also accountability of staff and accountability of service receiver, and record keeping and documentation. All of the things are included in the monitoring tools. These are the reporting flow, and basically the report is started from the center, and gradually it goes to, since it is the Global Fund granted program, so there are sub-recipient, then sub-recipient, then PR, and PR to then CCM and Global Fund and other government entities. And similarly, the feedback comes from the Global Fund and CCM and also the government entity to PR, then SR to SSR to the center. So with this process, we have a huge change, and 28% increase in general health service in 2023 to 24 compared to DIC model in 2022 to 23. And also notable reduction in the stigma and discrimination since service provided in the hospital, and hospital managed 248 complicated STI and 295 abscess cases with the necessary medication, and monthly operation cost, that is very important, house rent, electricity, water, consultancy fee, medical, waste disposal, guard, etc., is not required for hospital-based service delivery. This is at least 800 USD per DIC is realized. Yeah, if we relocated the service center from private setting to hospital. So there are still some gaps and challenges because still service providers are not fully ready, and also there are limitations of space, and there are issue of readiness and from the PUID as well, and also the non-acceptance of PUID in the society creates barrier to health-seeking behavior, and these are the basically major gaps and challenges. And so what we can do, we can do well coordination between PUID with service center and hospital, and we need to have training, orientation, awareness, and sensitization for hospital staffs as well as people who use drugs, and we need to engage support from UN agencies and seek support for technical assistance and also study tour for better or good example. These are the some pictures for integration of hospital. Thank you all.
Thank you. Thank you so much. Yeah, please have a seat. Okay, before I recap, so I'd like to open the floor for any questions, comments, clarifications, additions, because we have time. Either we can also leave early because this is the end of the day. No? Great. This session is very clinical. Everyone, all the speakers on time, and no questions as well. Okay, so I mean, as a chair, just to summarize some of the things, I think there are lots of hopes in this presentation. I think that's the key message that I see, because from each presentations here, I mean, with the global state of harm reductions, we saw there is a lot of increased uptake, in the harm reduction services. The number of countries, not just the harm reduction services, for the general populations, but also at the prison setting. I think it has increased. The only thing I think that the only hiccups that we saw there is the policy level commitment. It's still not translated into actions, in particularly for the funding allocations, and that's where all the advocacies and all the campaigns where Paulina has mentioned has come up into, and that's still a hope, at least because we have a way forward. I mean, we're not stuck there. And with Achille, we saw that the domestic funding for the harm reduction is possible. And what we also saw is it's not just the domestic funding; it's a social contracting, and it's a big difference. So we could have a domestic funding. There could be a big number of domestic funding, especially one of the tricky thing is government purchase a lot of ART. So in the budget, the domestic funding for the HIV is huge. And of course, it's ART, and then it's a life-saving medicines. But the crucial advocacy activities, the crucial network strengthening activities, the community-led responses, they all fall behind in this domestic funding. So that's where the social contract comes into the context to to continue some of those crucial things, community-led responses, the advocacy. And from the Achille's presentations, I think what I got the message is, if you're strategic, if you're able to foster good collaborations, and in particular, if you know your government well, if you can speak the government language, if you can navigate through the regulations of the government, I think things can be achieved. So that was amazing. And from Henry, there are a lot of things actually. There are a lot of things, but to me, what I received is innovative financing. One is, I think, in the moment of, especially, I mean, we have a slightly different context. You're coming from the US, you're not accessing the international funding, but the people from the global South, where we're so much dependent on the international funding, and with this US funding crisis, things have gone so alarming. So I think your presentation provides, some sort of hope that, if we can explore some level of financing, innovative financing, value-based partnership, I think that's another keywords. If we can understand the value of your partners and then leverage that, I guess it will produce a lot of positive results. And finally, integrations. I guess, so there's, I think with the integrations, one of the challenging thing has always been, with the key population is the government versus beneficiaries. I mean, we can do the integrations at a lot of, places, but it hasn't worked out well because people, they don't go and access the services. And that, I think that's what he has highlighted there. And then through the consultative process, through different other, nuanced approaches, and especially the tailored approach, the services that are acceptable to the key populations, I think, and the outcomes, very tangible outcomes in terms of increased access, effectiveness, efficiency, in the spending. I think those all have kind of validated that this integration is working well. So yeah, I mean, I see all a lot of hopes here. So before we close, I give one moment to all the speakers, if any final message from your side, to summarize, or any other messaging from your side to also to conclude this day. Paulina.
I think it's working now. Yeah, thank you. I just realized that maybe my presentation wasn't that hopeful, but but I wanted to let you know that I think that we do have a lot of things to be hopeful for. And I know that right now it's just like a very complicated situation with the funding, and also like emotionally speaking, I think that it's very hard. But at the same time, I feel like so many good things have been happening, and it's because of the community that is building those things. So I think it's good to keep that in mind. And also, through all the years of the report, of the Global State of Harm Reduction report, we have seen an increase of many harm reduction services. And I know that maybe just the numbers for some of you might not mean a lot, but I would say that it's not only about availability, it's definitely about the quality of services that in so many places they have been increasing as well. We have been tackling so many barriers, or at least recognizing the barriers that we still need to tackle, which is an important step as well. So I just wanted to leave this session with a negative note and just remind ourselves that we support and we are this community. And I think at the end of the day, we are going to continue advocating for funding because we have to. But at the same time, I think that there are many other very good things that we need and we are doing to provide better and expanded services, harm reduction services around the world. So that's it.
Thank you, Paulina. Achille?
Thank you. Yeah, I just realized that actually to changing the government approach to increase the harm reduction budget is not only advocate the budget itself, but also advocate the mandate of government about their approach. Because if their approach is only supply and demand reduction, it will be very difficult to them to develop the budget for harm reduction. So I think to channel of the advocate should be held not only to increasing the budget, but also to changing the mandate of the government. Thank you.
Gotcha.
Thank you again for listening us. Basically, funding situation is being rapidly changed and will be changing. So we need to think alternative funding and alternative approach to ensure sustainability for the service of key populations. And mainstream is the one of the best ways, because it will not be wise to isolate the key populations. We have to mainstream. However, it is difficult, but we have to start. The sooner the better. I think it will be sustained if we can accommodate them in the public health system of government facility, and that we can replicate in our country to mainstream the service of key population in the government hospital. Thank you.
Thank you. Henry.
Collaboration is key. Leveraging partnerships is important. And going to a place that, you've never been is scary and uncertain, but there are incredible amounts of opportunity there. And so I want to encourage us to continue to take the risk.
Thank you. Perhaps a round of applause to all speakers. Thank you. Thank you, speakers. Thank you to all of you as well, because you have been listening the whole day. And it's not easy to listen all the time. So thank you so much. So for that, I think we still have 20 minutes, but we're closing off now. So enjoy your day. Thank you.